All right, guys, buckle up. This is my journal club. My preceptor is Dr. Talente. Thank you so much for walking me through these articles and joining us tonight. Neither of us have any disclosures to make about the following presentation. So we're gonna do the not fun part first. If you are like me, statistics makes you feel a certain way, and that way is not great. But these concepts of sensitivity, specificity, positive predictive value, and negative predictive value, I think you'll pretty much see these concepts on every single board exam or standardized medical exam you ever take. So I have to review them every single time just to get them straight. I have to draw this table every single time, but I just want to review these concepts because they're not going away and you see them pop up in my second journal article. So the table that you see above is always divided into the actual numbers, people who actually, total population, the number that actually has the condition, and the actual number that does not have the condition, and then whatever test or intervention that you have up at the top. True positives are defined as people who test positive, who have the actual positive, who are actually positive for the condition. False positives are the ones who test positive who don't actually have the condition. True negatives are the ones who test negative who truly do not have the condition, and false negatives are those who test positive or actually negative for the condition. Or sorry, they test negative or actually positive for the condition. You take these numbers and you take this table, and then you can calculate the following values that you see down here. So first we have sensitivity, which is where you take the number of true positives and divide it over the number of true positives and false negatives. Essentially, by doing this, you're finding the probability of a positive test revealing that a patient has the disease. So what does that mean? This is the snout concept, where if you have a test that's very sensitive and it's negative, that means it's very likely that you have ruled the diagnosis out and the patient does not have it if the test is negative. On the other side of it, there's the concept of specificity, which is calculated by taking the number of true negatives and dividing it over the number of true negatives and the number of false positives. And that gives you the probability that you get a negative test for a patient that is negative for the condition. Other things that you can calculate on this table, the positive predictive value, it tells you the likelihood that someone with the disease is going to be positive for the test. It takes the number of true positives over the total number of true and false positives. And then on the other side of it is the negative predictive value, which takes the number of true negatives and divides it over the number of true negatives and false negatives, which tells you the likelihood that someone with a negative test is negative for the disease. Okay, that was a lot, but that was necessary. So let's move on and let's go into the first article. So the first article that I wanted to talk about today is predicting the need for phototherapy after discharge. And the reason why I chose this article is that jaundice is a very common condition. It affects more than half of all newborns, up to 80% of all newborns. We screen jaundice very vigilantly in our newborn population, so we really don't see chronic anymore, but there's probably at least one patient a week who comes into the hospital for hyperbilirubinemia, whether it's due to their risk factors or they followed up in an inappropriate amount of time. And this article looks at a different kind of model for determining whether or not newborns are going to be at risk of being above their phototherapy threshold compared to the traditional model that we're using right now, which is the Butani nomogram, which takes the bilirubin a certain time interval after birth and plots it on a low, intermediate, or a high risk And then you have to take that risk, and then you have to figure out what your actual phototherapy threshold is. So this is the purpose of this study. The people who made this study were trying to develop a new predictive model to determine the risk of increased total serum bilirubin over a treatment threshold after discharge. And the model that they created was based on the difference between their total serum bilirubin that was measured right before discharge and the treatment threshold at the time of discharge. They called that delta TSB, which is essentially how far away you were from meeting the bilirubin threshold to require phototherapy. So these are their methods. They created a retrospective cohort study, which means they did a bunch of chart review, and then they applied their model based on what they were able to find in the charts. This took place by collecting data from 11 different Kaiser Permanente facilities in California. The bilirubins that they looked at occurred between the ages of 12 hours and 120 hours of life. They wanted to study healthy infants, so they had some pretty stringent exclusion criteria. So they excluded kids who were there who were vaginal deliveries who had to stay longer than 72 hours, and C-section deliveries who had to stay for longer than 120 hours. They excluded people that had a direct bilirubin that was more than 50% of their total serum bili, which indicated that there could be something wrong other than the causes of indirect hyperbilirubinemia. They excluded anybody who already hit their bilirubin thresholds for phototherapy, and they excluded anybody who got treated sub-threshold before they were discharged in order to get the most accurate data that they could. This table to the left, you see a breakdown of the subjects that they had. You notably notice that they had a pretty large sample size. They ended up studying a group of 148,000 infants. So that's pretty impressive. You see the breakdown of their race, their size, their gestational age, risk factors that they might have had. So like their gestational age, what are they eating, whether they were DAT positive or negative, or whether that was unknown at the time. So here's the protocol. So they created two different models. The first model is called the delta TSB, and that is essentially the difference between the bilirubin at discharge and what the AAP phototherapy threshold was for them, accounting for both gestational age and positive DAT. And then they broke these down into categories of 1 milligram per deciliter intervals. So they start from 0 to -1, -1 to -2, -2 to -3, et cetera, all the way to -7. If they didn't have enough serum bilirubins in the chart, they just created an assumed total serum bilirubin at birth, which was 1.7. Then they created a more robust model. It is delta TSB, but it also takes into account the rate of rise of the bilirubin, gestational age, the timing of the total serum bili after birth, and patient feeding, etc. And then the outcome that they were looking for, was whether or not there was you're going to achieve a total serum bilirubin above the phototherapy threshold at 3 different time points. So they looked at within 24 hours and within 48 hours, as well as quote ever, which essentially encompassed the first 30 days of life. The 24 and the 48 hours are usually the follow-up time periods that we recommend for kids who follow up after their discharge from the newborn nursery. Okay, so here's the first table of results. So here they're comparing their delta TSB model to the Butani nomogram. So what you can see is that they kind of match up. So using the Butani nomogram, people who fell in the high intermediate risk group were predicted to surpass their phototherapy thresholds within the 24 and the 28 hour periods at both 20% and 29%, and 2% and 5%. Then taking the change in total serum bili or the delta TSB in the different categories of -0 to -1 below your threshold at time of discharge, -1 to -2, or -2 to -3 at the time of discharge, you see that within for the closer you are to the threshold at the time of discharge, the more likely you are to exceed your phototherapy threshold sooner. So those who are within one of their phototherapy threshold at the time of discharge, ideally followed up within 24 or 48 hours, because as you see, 50% or more of them were going to exceed their phototherapy threshold within the 24 and the 48 hour periods. Similarly, looking at the subsequent categories, you see that there's a significant drop off once you're greater than 3 below your phototherapy threshold. You're only looking at about 0.4% or 3%, depending on if they follow up at the 3 or the 48 hour mark. You see that the data is actually pretty impressive looking at your confidence intervals, that it looks like all the data that they found is actually pretty significant. So here they're plotting an area under the curve for all three models. So again, you have the traditional model that we use, which is the Butani nomogram, area under the curve predicting 88% accuracy of when a patient is going to exceed their phototherapy threshold. We have the delta TSB model that accounts for DAT and gestational age, that also appears to have pretty good accuracy compared to the traditional Butani model. And then we have the delta TSB plus, which again, it's comparative to the traditional Butani model that we're currently using. So based on what they were able to find by running their models and comparing it to what happened with the patients who used the traditional Butani model, it looks like these new models are pretty good at lining up with what actually happened with the patients. And it seems like the predicting value of these new models is actually it seems like it's pretty accurate in its ability to predict whether or not a patient is going to meet their phototherapy threshold at some point. They broke down the data further into different subgroups to see if there was similar accuracy in being able to predict whether or not patients were going to meet that threshold. So we've got people, so the different groups that they have are a total serum bili that was checked less than 24 hours of life, greater than 24 hours of life, gestational age less than 38 weeks or greater than 38 weeks, whether the patient was DAT positive or if the DAT status was unknown. And here we see that there continues to be really accurate findings between all three models, regardless of what the subgroup or what the, I guess, what the other factors at play were. And it looks like comparing the Butani model to the TSB model and the TSB plus model, it looks like the authors are trying to indicate that based on their study and their findings, they think that the TSB plus model or the TSB plus would have a higher accuracy in predicting whether or not a patient is going to meet their phototherapy thresholds compared to the Butani model, as indicated by the higher or the larger area under the curve compared to the Butani model. And then here's a table that again compares the model that was developed by these researchers based on this model compared to the different categories of the Butani model. One thing that this paper decided to point out was that they think the Butani model is a little bit more conservative in who they put in the high, intermediate, and the high categories compared to the Delta TSB model. And they notably say that the Butani model will contain patients who, based on the Delta TSB model, would be up to -5 or -6 from their phototherapy threshold, and place them in the high intermediate category require them to have follow-up probably within the next 24 to 48 hours, even though only about less than 2% or less than 1% would actually end up having an adverse outcome requiring phototherapy. So based on this data, the people who created this study were suggesting that if the Delta TSB model could potentially, if it's more accurate at predicting whether or not patients are going to meet their phototherapy threshold based on how far they are from their phototherapy threshold at discharge, they think that this could be a way to cut down on the number of return visits or unnecessary visits to the doctor's office. So here is the discussion. So essentially this study was saying that the new model that they created, the Delta TSB and the Delta TSB plus, are both effective in predicting future total serum bilirubins and predicting which ones are going to be above the treatment threshold. Because they're able to predict this, they're helpful to determine whether or not kids need to follow up their bilirubin. They also found that your pre-discharge bilirubin plays a huge role in determining whether or not you'll need phototherapy, and it's a good way to estimate what your risk is going to be, and then down the line. The Delta TSB Delta TSB and Delta TSB plus yield the best results when they accounted for additional variables, especially gestational age being the biggest factor. They also found that you are likely to have more accurate predictions if you account for, again, factors such as gestational age and hemolytic disease. Let's see. And then again, they're saying that this model might be good for determining whether or not a patient needs to follow up or when the patient needs to follow up so that we don't miss the peak of their bilirubin, or we don't test too soon. So we don't test too soon and we don't catch the patient when it's too late. So what are strengths of this study? Strength of this study is the incredibly large sample size. There were, I think, like we said, almost 150,000 participants who were enrolled in this study, which a lot of times I feel like you don't see numbers like that in these initial studies. Other strengths, I like that they use the total serum bili instead of the transcutaneous bili, because that is the gold standard of assessing bilirubin. We look at kids who are in the newborn nursery and turning yellow. Limitations of this study. It's a retrospective study. So all data that was collected was dependent on data that was available in the EMR. And sometimes things aren't documented very clearly, or you're limited on what you are able to find in the EMR. So sometimes it's not the most complete of documentation, especially when breaking down information to those subcategories that we saw, although it doesn't. So yes, that. And then other limitations, because it's a retrospective study, you can't really call it a direct head-to-head comparison at this point with what they're able to find in the data. You can really only say that this model works and can be applied and can show similar results compared to the Phototherapy of whether or not patients are going to meet their phototherapy threshold. So in terms of how does this article play into future clinical practice? Well, it seems like it has potential, but this study is not enough to actually say whether or not this model is more effective than using the Butani nomogram, because again, it is not a direct comparison. It's just showing you that it works, or that you can get similar results when you apply these models compared to the current gold standard. Additionally, there's this idea that using the current methods of looking at the Butani nomogram to determine what category of risk they are at of exceeding their phototherapy threshold, and then requiring is like step one, and then step two is going back in to figure out what their actual phototherapy threshold is time consuming and confusing, because some people think that the Butani nomogram is actually telling you a number or a threshold, or telling you how to manage your patient with when you should start phototherapy. So there's this idea that the current way of assessing hyperbilirubinemia is complex and time consuming, and the idea that the Delta TSP model is going to cut down on time. However, given the current tools that we are using to assess management of patients in their hyperbilirubinemia, a lot of it is already on the computer. And it seems like the way that people have created these programs, like Billy Tool, it kind of does both at the same time. So it gives you, when you enter in the age of which you've gotten your Billy and the serum Billy, it does already spit out the different categories and what those thresholds are. So will this truly save me any time in my management of these patients? It doesn't seem like it, because it seems like we're already kind of at that point, but I'm not a computer programmer, so it's possible that this could be useful for people who create these calculators later on down the line, especially if there appears to be higher accuracy. If that can be proven in a direct head-to-head study, maybe we'd be able to change the suggestions and the guidelines that come out at the end that talk about when the patient should follow up next and have another check, or if they need to be checked again. Any questions? Any comments?
Good job, Diane. That was a great article.
Thanks, Jaya.
Yep, I think you did a good job summarizing it, because I think the important point with articles like that, it's a well-done article to look at this new model but you have to be very careful when they put their data compared to other data on a retrospective study of, and I think you made an excellent point. You stressed this point of think of it as a true comparative study, which it really isn't, right? So you have to be careful to judge their new model as better or superior. And I think you really made that point, which is probably one of the most important points in an article like that. Because when they put that graph you showed of their end of the curve, they want you to kind of think their model looks better because its curve's better. But you have to really be careful. And so I think that was one of the really important points that you mentioned. But I mean, obviously their method seems to be potentially good and potentially better, like you said. But that's sort of one of the tricks with some of these articles is, you know, they're, especially if we're not statisticians, because this was kind of complicated, statistics and stuff.
I was going to ask about the electronic implementation, but then you kind of addressed that because you're awesome. So that's all I got.
All right, let's move on to the next one. So the second article that I have is titled "The Predictive Value of Clinician Gestalt in Pediatric Community Acquired Pneumonia." This study kind of looks at kids who present to the emergency department who get diagnosed with community acquired pneumonia and whether or not they and categorize them as mild, moderate, severe, very severe disease, as well as what the doctor at the time thinks is going to be their outcome if they're at high risk of a bad complication or if they're going to be fine. I thought this article was interesting and applicable because if you're not admitting a patient to the hospital, you're kind of taking a risk every time you assess a patient. So you're assessing a patient and based on your assessment, your history, the physical exam and what they're looking like in front of you, and plus or minus lab work, depending on what you're able to do in your office or in the emergency room, you make the decision of whether or not to let them go, which anything could happen. They could acutely decompensate and end up coming right back, or they could get better and be fine. So we apply this to outpatient practice and emergency departments. And I just wanted to see if experience or gut feeling or whatever it is that makes Gestalt for physicians is a way that we can predict the eventual outcome or the risk of developing severe complications with community acquired pneumonia. Okay, so the point of this article was to determine if clinician Gestalt is an accurate predictor of severe outcomes in children with suspected community-acquired pneumonia who present to the emergency department. The primary outcome of this study was the development of severe disease or complications after the initial emergency room visit. And the secondary outcome was a breakdown of the outcome representing increasing disease severity within 7 days as mild, categorizing them as mild, moderate, severe, very severe disease. So here we go. This is a study design. It was conducted at Cincinnati Children's Medical Center between July 2013 and December 2017. They selected children who presented to the emergency department ages 3 months to 18 years that had signs and symptoms of lower respiratory tract infections, as well as a clinical chest x-ray that was suspicious for community-acquired pneumonia. They started with a total of 1,165 subjects. They ended up excluding some because they had been hospitalized within the last 2 weeks or something similar. They had some kind of predisposing condition that made them immunocompromised or some kind of chronic medical condition. Or they had a history of aspiration or aspiration pneumonia, or they decided they didn't want to be part of this study anymore. And then they took some more of them out because the clinicians didn't do their job in documenting their predictions for whether or not these kids were going to develop complications. This is the cohort that ended up being part of the study. So the 634 is the number that actually ended up being studied. So their median age is about 5. It's a decent split between male and female. This is their breakdown of their race, their disease severity, notably that most people fell in the mild disease severity category, and much fewer of them fell in the very severe category. And then what ended up happening with them, whether they were discharged, whether they got admitted to the general floor, whether they made it into the ICU. And then, so after the physicians saw the patient, after they saw them, after they reviewed their test results, they were asked to categorize the patient into a different risk category of less than 1% likely to have a severe outcome, 1 to 5% likely to have a severe outcome, 5 to 10, 10 to 25, 25 to 50, 50 to 75, or 75 to 100%. They defined severe disease or severe outcome as respiratory failure with or without intubation, developing an empyema or effusion, or a lung abscess or lung necrosis, disseminated infection to other sites such as sepsis or osteomyelitis, bacteremia or osteomyelitis, sepsis, septic shock, or death. And then they were also asked to categorize whether or not the patient was going to become mildly, moderate, severe, or very severely ill. Oh gosh, where did it go? Okay, so here are the different categories that the emergency department clinicians were asked to categorize the kids in. From what you see, most of them thought that the kids were going to be just fine. And so more than a third of them were categorized as either from 0 to 5%, essentially. Actually, that's even more than half of them. And they were pretty right. It seems like most of them did pretty well and didn't have severe complications. And of the ones who probably looked pretty good and the ones who they decided were not going to be at very high risk of developing severe complications, only a handful of them developed severe complications. And then the ones who were sicker and probably ranked or categorized in the categories of having a higher likelihood of developing severe complications, there were fewer of them, but it seemed like as you go up in severity, the number of severe complications increases compared to the ones who they deemed as looking pretty good and probably not going to develop severe complications. And then again, they did kind of another step where they broke down the sensitivity and the specificity of the patients who were in these different categories in different thresholds, and broke that down further into how they were categorized by patients that had less than 5 years of experience versus physicians who had less than 5 years of experience, or physicians that had more than 5 years of experience. And what you'll notice is that it kind of all lines up across the board. So they're pretty good at figuring out which patients were at low risk and which ones were at higher risk. You'll notice the general trends in sensitivity and specificity across the board. Sensitivity is higher in patients that are at lower risk of developing complications. And it seems like it is lower for patients who are at higher risk of developing complications. For specificity, you see that it's higher when patients are looking more acutely ill and like they're going to have a higher likelihood of having more severe complications. And then here our friends are positive predictive value and our negative predictive value, which tells you the likelihood that a positive test is positive or truly positive, or a negative test is truly negative. So in this case, you're looking at whether or not somebody who truly had severe disease compared to the people who were predicted to, or the total people who both predicted and actually had severe disease. And you see that positive predictive value increases in the categories that it seems like must have appeared sicker to the physicians in the emergency department. They also did another area under the curve graph, and this is just another way of showing that all clinicians were able to predict whether or not someone's going to have a severe outcome of their community-acquired pneumonia. They're all pretty good at it. It seems like the experienced clinicians who've been in practice for more than 5 years might have been a little bit more accurate than the physicians who have been in practice for less than 5 years. But overall, the general trend appears the same. So, conclusions. Clinicians are more accurate at predicting disease severity in children classified as mild and severe. So the extremes by Gestalt and those that are classified as moderate. However, one of the concerns about the study was that most kids actually fell in the moderate category. So that ends up being a lot of gray area. And it seems like we're not, or the people who were part of the study were not as good at predicting what the eventual outcome was going to be for these kids. And then the other conclusion is that based on the cutoff of 5 years, more experienced physicians have a slightly improved sensitivity for severe complications and a similar specificity compared to those who are less experienced. Strengths of the study, again, there's a decent sample size of 600 kids. It occurred over 4 years, capturing many different seasons and many different times of year. And they truly go for this idea of Gestalt, where they don't tell you, they don't go into the thought process that each physician has, so you don't truly know what is it that they put the most value on, or if they're going by a gut feeling. Limitations of this study. So again, most kids are healthy. They had a pretty small sample size of patients that have severe outcomes. They could improve upon this by just gathering more data on this study and hoping that you capture more patients that have severe outcomes. And then looking at the article, it looks like they didn't even tell the clinicians what they meant by when they told them to categorize them into this disease category of mild, moderate, severe, and very severe. So it's also possible that the physicians who were part of the study were thinking differently compared to what was intended by the people who created the study. Another thing that Dr. Talente and I had kind of talked about too was the idea of an experienced doctor versus an inexperienced doctor, and the cutoff of 5 years, and whether or not 5 years after training is truly sufficient amount of time to consider somebody experienced, and whether or not this idea of experience and how that correlates with your ability to predict outcomes, if that plateaus after a certain point, or if at some point it's like, at what point gestalt and actual outcomes will start lining up even more. So applications for clinical processes. I guess you can't really say I have gestalt. Being a second year resident, I guess we see kids all the time who come in through the ED, and you can say, oh, this kid doesn't look good, this kid looks good. But we still have kids who bounce back to the ED who end up getting admitted. There's different different considerations for why kids end up getting admitted to the hospital, whether it's social, whether they don't have a PCP, whether there's concern that parents are actually going to take them for follow-up. And then kids are just very, I don't know, they're very touchy. It seems like you see them one day and they look great, and then 5 minutes later they might not. So I think in clinical practice, I think I would just continue stressing to the family the importance of good follow-up and what signs to look for, to either bring them back to the emergency room or to get back to their doctor for additional evaluation. Because I think that the risk of telling somebody that they're going to be fine and they don't need to follow up does, and having something go wrong would be pretty devastating if it could have just been fixed with following up closely and continuing to assess the situation. Any questions or any comments about this one?
I have a question. So it's really interesting kind of the way that they, at least with that graph, it certainly does look like there's quite a big difference between less experienced and more experienced physicians. And I mean, that makes sense, but I guess, did the study look into it all? Like, there's a difference because they're picking up on, things that one person, a less experienced person would pick up on, like maybe a less experienced person just like didn't look at the respiratory rate or something stupid like that. Did they kind of stratify out these patients, like what their vital signs were, some sort of, baseline predictors of how bad their disease could end up being?
So they didn't actually mention any specific factors that each physician looked at or how they weighed those factors in their decision making. What Dr. Talente and I had talked about with this article was that, again, like kids who look good and kids who look bad at the two extremes, it seems like you can pretty much predict which way they're going to go, but most kids fall into the moderate category. So it might be a future direction to do another study to figure out what the risk stratifiers are, or what people are looking at when they decide what is going to be the biggest factor that results in a severe outcome of community-acquired pneumonia, and whether or not those kinds of factors could be implemented to create guidelines for determining what to do in terms of treatment for kids who present with CAP.
Guidelines, like, and kind of, so guidelines, I guess, is kind of where my head's headed with that question. Just especially, honestly, nerding out a little bit with, like, whenever they talk about someday robots and all these, different programs are going to replace everything we're doing. Is there a, like, je ne sais quoi kind of quality that the more experienced clinicians are bringing Or is it just, the less experienced clinicians are missing things or something like that? I think that would be an interesting thing if they were to add that for sure.
So I think in interpreting this difference, it's important to say that both groups were sort of similar in the sense that they were effective at that their very low risk assessment was very accurate and their very high risk assessment was very accurate, and their in the middle assessments really were not really so great. It's only a slight sort of difference. I don't think the experience data is really, I think it's kind of interesting, but I'm not sure it really adds tremendously much to this study, because I think the more global point is that really in the middle range child, Gestalt probably isn't good enough to really predict who is going to come back with a severe complication. And so then like the question is, what do you do about that? And I think Diane sort of talked about a couple different options. One being that suggests that follow-up is could be very important, and education of the parent. The other being, do we explore the value of additive components? And so this is where things like, procalcitonin and other sort of markers might become an additive point. Like if you have, moderate suspicion, does that move the dial to where it becomes more accurate? And that's where you get into like writing guidelines like we have for like sepsis, for serospectral infections in infants and things like that. But I think that the experience difference, because they don't really classify, 1 to 5 years, sure, but they don't tell you whether that trails off. Like, is there really that much of a difference between 5 and 20 years of experience? Or do you even get less good as you get, when you get to be my age, do you start to become less good? And this doesn't really explore that. So it's sort of an interesting finding, but I don't know that it's that in the overall picture too important. But that's a good job.
I just have to say, if you're using age and you get worse, then I might as well just hang it up.
So we don't know that we get worse as we get older. They just didn't study past the 5 years.
I know,
So like,
but I love that. But I love that supposition. Good job. I was just teasing. Good job, Diane.
All right, thanks for joining, everybody.
All right, good work.
Perfect.
Good job, Diane.
Okay.
Great job, Diane.
Good work, Diane. Thank you.
Have a great night, everyone. Thanks again, Dr. Talente.
You're welcome. You did great.